As Karen said, I'm one of the electrophysiologists at Methodist Hospital. And today we're going to talk about left atrial appendage closure, the indications for it, and in particular the Watchman left atrial appendage closure device, the procedure and the follow-up, and what to kind of look out for with these patients as you'll be seeing more and more of them. So why do we care about atrial fibrillation? Well, certainly everyone that works on the floor knows, I mean, right, every patient. It seems like every patient, at least every call that we get in the evenings, it seems to be for atrial fibrillation. But it's a huge problem. We know that about 5 million people in the United States have it, but it's way, way under-recognized. And you see this in the hospital or clinic, right? How many people come in with atrial fibrillation and they don't even know it? It happens all the time. So this 5 million number is, it's using cliche, just the tip of the iceberg sort of situation. And it's really increasing. Part of it is just due to aging population, sicker population, but I'll tell you, I see a lot of this in younger people as well. In fact, in a couple weeks, I have an ablation coming up, and she's a 36-year-old healthy person, and she has atrial fibrillation. So, why do we care about atrial fibrillation? Well, for a lot of issues. One is the way it makes people feel, the burden of suffering, the morbidity and mortality associated with it. It's associated with heart failure. It's tremendously expensive for our health care. But we're going to focus today on the stroke risk in atrial fibrillation. 1 in 5 strokes is caused by atrial fibrillation. And again, that number is probably higher because there's a lot of these patients that have this called cryptogenic stroke, meaning we don't know what caused it. And a lot of those actually turn out to be atrial fibrillation as well. And if someone has atrial fibrillation and has a stroke, about half of them have another stroke within the next 6 months. So atrial fibrillation and stroke is a huge risk factor for another stroke. So in atrial fibrillation, about 90% of all strokes, TIAs, whatnot, are caused by clots in the left atrial appendage. So this is, of course, the most egregious and obvious example of a left atrial appendage clot ever. But this is a transesophageal echo. So the echo ultrasound probe is actually put in the esophagus because the esophagus actually touches the left atrium, so we get beautiful views of the left atrium. And you can see there we go. So this is the left atrium here. This is the left atrial appendage. It's some vestigial leftover structure from when we were, it doesn't serve any, it's like having an appendix, it doesn't serve any, that's why it's called an appendage. It doesn't have any clear function, but it does tend to cause problems, just like it says. And this is a huge blood clot in the left atrial appendage there. You can see it there. These things can break off, and they can go anywhere. Every so often we'll see people get, intestinal angina or whatever, but it goes to their gut, it can go to the kidneys and cause renal problems. But a huge percentage of every heartbeat goes to your brain, because the brain uses so much energy. And even a tiny clot is very evident when it goes to the brain, so that's where they tend to be manifest or strokes. Is everyone familiar with the CHADS 2 VAS scoring system? Have people heard of this? Clearly, people with atrial fibrillation, not everyone is at the same risk of stroke. The young lady I'm going to be ablation is 36. Her risk of stroke is not the same as the 87-year-old who's had bypass surgery and has a cardiomyopathy, diabetes, and whatnot. So there's a scoring system called the CHADS 2 VAS. There's a couple different scoring systems that are used. This is now the most common one used. And it's a pretty simple point-based system. You get a point for congestive heart failure. And the question always comes up, what does that mean? Is it a low EF? Is it heart failure with a preserved ejection fraction? It's clinical heart failure. So if they come in, volume overload, that sort of thing, that's heart failure. Hypertension is another point. Age, you get 1 point for age greater than 65, 2 points for age greater than 75. Diabetes is a point. Stroke or TIA is 2 points. Vascular disease is another point, so that coronary artery disease, peripheral vascular disease, whatnot. And then sex, female gender is another point. And then you kind of add these up. If you don't have any points, the annual risk of stroke is pretty low. If you have 1 point, the annual risk of stroke is about 1%. And as of now, it's considered okay to use either aspirin or an anticoagulant, although the aspirin part of that is probably going to change But most people are 2 or greater, and if it's 2 or greater, some sort of anticoagulation is indicated. So if you are a 75-year-old woman, you already have a chance with 2 VAS of 3, even if you're perfectly healthy, no high blood pressure, diabetes, or whatnot. So anticoagulation, it has its issues. There's a lot of problems with anticoagulation. I think this slide is interesting because you'll see that it kind of peaks at about 50% with the people that have their CHADS 2 VASC of about 5 or so. And as you kind of get out into the patients that have the higher risk of stroke, the percentage of those patients that are anticoagulant actually decreases. And that is because many of the same risk factors for stroke are actually the same risk factors for bleeding. Age is a risk factor for bleeding, hypertension is a risk factor for bleeding, renal dysfunction is a risk factor for bleeding, people that are on aspirin, Plavix, and all these other things, people that take NSAIDs for arthritis, these are all risk factors for bleeding. And as the patients get sicker, these risk factors increase. Anticoagulants tend to be either discontinued or not started at all. So, our sickest people are the ones that are not covered, unfortunately. And as of now, we have essentially 2 choices for oral anticoagulants. One, of course, is warfarin, and warfarin's been around forever and ever and ever. And, I think we all know sort of what a pain warfarin is. There's a bleeding risk because it's a blood thinner. Daily regimen. There's a lot of non-adherence to warfarin. I think we all know that. INR monitoring, very difficult. It interferes with food. It interferes with other medications. It's not readily reversible. I know we said you can give FFP and vitamin K, but that's far from the media. The newer anticoagulants are certainly an improvement over warfarin, but they're far from perfect as well. They're still anticoagulants. There's a risk of bleeding. It's, at least in the literature, less than warfarin, but we still see it. Daily regimen, some of them are twice a day, which cuts down compliance as well. There's pretty high non-adherence rates. I have a lot of people that on their twice a day newer anticoagulants that take it once a day, often because of cost. And if you miss just 1 or 2 doses of it, your levels fall dramatically. Whereas at least with warfarin, it has such a long half-life. If you miss a dose or 2, it's not usually a little piece. It is. Complicated surgical procedures. There are some reversal agents available now, but they're not readily accessible in all areas, and these medications are fairly expensive. So these are the 3 most commonly used newer anticoagulants. There's a 4th one as well, but for whatever reason that one never really caught on. And to be sure, they're an improvement, but they're not perfect. The attrition rate is pretty high. You'll see here when you start, the green line is warfarin, vitamin K antagonist, and the red one is one of the newer ones. When you started, everyone, it's great for a few months there, and then after a few months, more and more people stop taking their medications for a variety of reasons. You see at 2 years, warfarin, about half the people stop taking it, and about 30% of the novel drugs, they stop taking it. So, if all these strokes or 90% of them come from a blood clot in the left atrial appendage, is there some way we can just plug out the left atrial appendage and avoid anticoagulants altogether? And for several years, there's been various techniques looking at this, everywhere from the surgeons where they just cut off the left atrial appendage to various devices. But the Watchman is the first one that's FDA approved, and it's the best study of all of them. And it's an alternative to anticoagulation for patients with atrial fibrillation and a high risk of stroke. Of all the device-based and surgical-based therapies available, this one is the best studied. Has had the most clinical data behind it. It is as good as warfarin to reduce the risk of stroke, but with a substantial decreased risk of bleeding. So who's a candidate? Patients that have a CHADS 2 VAS of 3 or greater. They do not have a mechanical valve, and for some reason can't take warfarin or anticoagulants. And this is just sort of another way to look at the same thing. So what's the appropriate, if you go back and look, it says they have to have an appropriate rationale for not taking anticoagulation. And that's sort of vague, obviously. These are some of the more common things that we see. The most common is probably history of bleeding. I would say at Methodist Hospital, we have an excellent, very active gastroenterology service, and probably GI bleeding is the most common indication that I see for Watchman. Intracranial hemorrhages as well, subdural hematomas, people that fall, people that have had sort of bad experience with anticoagulants, very, highly variable INRs, or people that have a difficult time, they might live out wherever, and they have a difficult time getting their INRs monitored. Renal dysfunction is another one that I think is a good indication for Watchman. It's one that I don't think we see a ton of as an indication, but patients with substantial kidney disease are at high risk of bleeding on anticoagulants. You know that especially the newer anticoagulants, although there are some data in the setting of severe renal dysfunction, there's not a ton. And then occupation, someone's a race car driver, carpenter or whatever, or if they have a lot of falls, these are also indications for Watchman. So this is what the device kind of looks like in a little cartoon form. It's a one-time implant. It's not like a pacemaker or ICD that needs a generator change and that kind of thing periodically. It goes in, stays in. It's done by sort of a team. We do it, and I think many centers do it, is there's 3 cardiologists involved, myself from the electrophysiology aspect, Ed Viksinski from the interventional cardiology aspect, and the 2 of us scrub it together. And I think as an interventionalist and me as an electrophysiologist, the way we kind of handle catheters in the left atrium is very different but complementary. And then Tracy Jurgens does all of our TEEs, which is a very important part of all this. And then there's always someone from Boston Scientific who makes the device there in the lab as well. And then Tina, who's right over there, our Watchman coordinator, who helps out getting everything scheduled and answering patient questions and identifying patients that are candidates and whatnot. The device goes in through the femoral vein, the right femoral vein. They're done with anesthesia. The cases take about an hour, and then patients stay one night in the hospital. And here's what the device looks like. It comes in 5 different sizes. It goes actually in the left atrial appendage, not dangling out in the left atrium. It has a nitinol frame. And nitinol is a titanium nickel alloy, which is important to know because I had to deny one patient because he has a pretty substantial nickel allergy, and that's actually contraindication to the device. It has 10 little spines on it here that kind of fix the device. The actual base of the device has this fabric that's designed to block blood from getting in or out of the left atrial appendage. After the device goes in, and we'll talk a little bit about follow-up as well, but people do go home on an anticoagulant for 45 days. The party line isn't supposed to be warfarin, although we also use other anticoagulants as well. We get another TE to look at the device to make sure everything's looks good with it, and then 92% of patients can stop their anticoagulant in a 45-day TE. If that one doesn't look good, we get another one in 6 months, and 99% stop by then. I don't know if you're
okay. This is Watchman, a left atrial appendage closure device, and the only implant of its kind approved by the FDA. Watchman is for patients with non-valvular atrial fibrillation who need an alternative to oral anticoagulants. In a one-time procedure, Watchman offers stroke risk reduction comparable to warfarin, while avoiding the risk of bleeding associated with long-term warfarin use. In patients with non-valvular AF, over 90% of stroke-causing clots that come from the heart originate in the left atrial appendage, or LAA. Watchman is designed to permanently close off the LAA, preventing those blood clots from escaping. The procedure is performed under general anesthesia in a catheterization lab using fluoroscopy and transesophageal echo. Typically, it takes about an hour, and patients stay in the hospital for 1 day. Using a standard percutaneous technique, the implanting physician inserts a guide wire and vessel dilator into the patient's femoral vein. Then, using a standard transseptal access system, the physician crosses the interatrial septum. The physician advances the access sheath over the guide wire into the left atrium and navigates it into the distal portion of the left atrial appendage over a pigtail catheter. The physician then deploys and releases the Watchman device. The device gradually endothelializes to permanently seal off the patient's LAA. Following the procedure, the patient takes warfarin and aspirin for at least 45 days, or until the LAA is adequately sealed. The seal is confirmed by transesophageal echo. After discontinuing warfarin, the patient takes clopidogrel and aspirin, followed by ongoing aspirin therapy. The FDA approval of Watchman is based on data from 2 randomized trials and 2 prospective registries, including 2,400 patients and 6,000 patient years. Additional real-world safety data was collected on Watchman in the first year after FDA approval. Watchman was successfully implanted in 95% of patients in the PREVAIL clinical trial and in the post-FDA approval experience. In both of these data sets, a significant number of operators were newly implanting physicians. Clinical studies of Watchman show consistently low rates of device and procedure-related safety adverse events since the second half of PROTECT AF, when refinements were made to the device and procedure. These rates are comparable to those published for AF ablation, another left-sided procedure. In a meta-analysis of the clinical trials, Watchman reduced all-cause stroke comparably to warfarin. Patients who received Watchman also experienced a significant reduction in major bleeding events compared to warfarin as early as 7 days post-procedure. More than 6 months post-procedure, Watchman patients experienced a 72% reduction in major bleeding events versus warfarin. The Watchman implant, an innovative alternative to oral anticoagulants. See if Watchman is right for your non-valvular AF patients.
Okay, so a little bit about the procedure. We'll talk about the equipment and sort of steps. The first thing we do is actually assess the left atrial appendage size, anatomy, and morphology, cross the interatrial septum, navigate the sheath into the left atrial appendage, deliver the device, and then there's some criteria that we use, 4 different criteria to determine whether or not it's a good device and that we leave it, what to do if the device needs to be repositioned, and then finally releasing it. So the equipment that we use, so there's a delivery system and catheter, it's all preloaded, and actually there's some examples of it out in the hallway there if you have a chance to go look at it. You can kind of get your hands on it. We do use a venous introducer, which is just a sort of kind of medium length outer sheet to help manipulate the catheter, and everything goes through that. I think it just makes things a little bit easier. These transseptal access system, we do these for all of our atrial fibrillation ablations as well. We do it essentially the same way for these cases. Pigtail catheter to help manipulate the system in the left atrium. And again, this is another one of these deals where I think having interventionalists as well as electrophysiologists are good, because for atrial ablations, I've crossed the septum, a zillion times, but pigtail catheter is nothing I ever use, whereas Dr. Krasinski uses these pigtail catheters all the time. So again, it's just nice to have both of us there. TE, all these are done with TE guidance during the actual implant procedure. The TE person, I think, is the most important person in the room there. We anticoagulate just like we do during any left atrial procedures. We usually run the ACTs 350 to 400, just like I do for atrial ablations. And then in terms of what we have in the hospital, obviously electrophysiology, interventional cardiology, and then we have to have cardiac surgery backup. They do not need to be there in the procedure, but there needs to be a surgeon somewhere in the hospital available. So this is what the delivery, the access sheet looks like. It comes in 3 different curves. The double curve is by far the most common shape that we use, and it depends on the left atrial appendage anatomy and where its takeoff is relative to the intraatrial septum. It also depends somewhat on where we're able to cross the intraatrial septum, but the vast majority of them, we use the double curve. On occasion, the anterior curve, and very rarely we use the single curve. And this is the actually delivery sheet. That's the device. See, it's folded up kind of like an umbrella, and it's nicely tucked right inside there. You can see on that distal marker band, those are the little feet of the device. It's a 12-French outer diameter, so it's the same size sheet we use for atrial fibrillation ablation. It's 12-French inner diameter sheet. So the first step involves assessing the left atrial appendage dimensions and anatomy. So a TE is a two-dimensional view, and we're looking at a three-dimensional structure, so we get 4 different angulated views to try and kind of at least mentally recreate this three-dimensional structure the best that we can. These are the standard views that we use. So we measure a couple things in each one of these views. We measure how wide the orifice of the left atrial appendage is, and then we also measure the depth. And the depth is very important because this device is as wide and it is long. So probably the most common reason we can't deploy devices is because the left atrial appendage is too shallow, and that the orifice is bigger than the appendage is long. We can't kind of get it in there. So we look at these measurements, and then we use the biggest diameter to help size our device. We really broadly define the left atrial appendage into these 3 sort of anatomical variants. The first one is the windsock, which is just one big lobe. That's perfect. That's our dream. We love it. Barely ever see it. But those are the easiest ones to do. Chicken wing seems to be the most common one that we see, which of course is the most difficult one to deal with, because that's when the left atrial appendage is it literally just folds back on itself. And the way it kind of does it relative to the intraatrial septum can be kind of tough, and it just depends on how much this little, how much of a little neck on it here. Let's see if we have to put the device. And then the third one is sort of lumped into broccoli, which just means it's really complicated, lots of little fingers. And these are variable. Some of them are not bad. If there's a little lobe we can get into and anchor the device, others can be kind of challenging. You can use contrast echocardiography as well. I don't think that we've ever had to do that though ourselves. And then sizing the device, you look at the maximum diameter of the left atrial appendage orifice, and then you want the device to be about 8 to 20% compressed. So you pick a device size that's just a little bit bigger than the left atrial appendage orifice. Crossing the intraatrial septum, this is so just to orientate you to the view here. This is the right atrium, this is the left atrium, and this is the superior and inferior vena cava. These are actually backwards. And then this is the aorta. So we use this view to see how sort of superior or inferior we are, and this view to see how sort of posterior or anterior. So we want to be obvious, this is the aorta, so you want to stay away from that. That's not a good place to put your transeptal deal. And then we want to be kind of inferior as well, because the left atrial appendage tends to be kind of superior to the fossa valgus, so you kind of want to look up at it. It just makes getting in there a little bit easier. And then there's the ideal place where you want to cross the intraatrial septum, but then there's also the reality of just where you can physically do it as well, which can be kind of dependent sometimes. And this is what the access sheet looks like. It has these markers on it, and these markers tell us kind of how far we need to go to get a given device in. There's different markers on it. So essentially, if you want to put in a 24 millimeter device, you have to get up to here on the sheet to have enough room for the left atrial appendage to do it. And we look at multiple views on cine, and we do some contrast injections to make sure that we have the sheet deep enough in the left atrial appendage. And we do all this over the pigtail catheter or the manipulation so that we don't push the sheet around the left atrium, which can cause a perforation. Then we select the device, and this is what it looks like inside the delivery system. And then one of the important things for this whole deal is you never, once you kind of line up the tip of the delivery system with the tip of the sheet, you never want to push the delivery system out because that could cause a perforation. So you unsheath the device, you pull the sheath over the delivery system. You never want to advance it. And this kind of just gives you, see, that's what the tip of the thing looks like when it comes out of the sheet here. So kind of, if you push that, you can cause some problems. So no forward motion. And then once the device is deployed, we look at these pass criteria: position and the occipital left atrial appendage. Make sure the device is anchored and fixated in there well. Make sure the size is proper, that we have the right compression ratio, and make sure that it's healing all the lobes of the left atrial appendage and that there's no blood flow around it. So the device should be just distal to the left atrial ostium. If it's a little bit out, we call it a shoulder, essentially sticking out a little bit. And we'll accept some degree of shoulder, but the least possible is what we want. Obviously, this example is a really good one where it's right in perfect position. If it's too distal, that can leave a lobe uncovered, and you can get flow still in and out of the appendage. And this is not terrible to deal with. We can kind of recapture the device. We call this a partial recapture, because we don't actually pull the device all the way back into the delivery system, just up until where the kind of anchors are, and you just pull it back a little bit and redeploy it. If it's too proximal, this is a little bit more of a problem. We worry about the device not being compressed enough. We worry about it not being stable. We worry about it embolizing and flying off somewhere, which is obviously an issue. If it's too proximal, you have to recapture the whole device, and once you recapture the device, it goes in the trash or finds its way to some sort of like the table up there or whatnot. So, but if that happens, then you have to, if it's too proximal, you have to take the whole thing out, recapture it, and then go back in with the pigtail catheter and manipulate back to the distal left atrial appendage. Anchor, you have to make sure that those little feet are kind of embedded into the left atrial appendage. And then we do the tug test, which is one of my favorite parts of the procedure. You kind of yank on the thing and make sure that it doesn't fly off anywhere. So we look both on fluoroscopy to make sure it kind of snaps back. We also look on T to make sure it doesn't. If you pull on it and it dislodges proximally, that's probably not a good device, because then there's a risk of it embolizing. And then compression ratios, in terms of the size of the device versus how much it's compressed, we want to compress the 8 to 20%. So on T, you can see how they did the measurement here, right at the sort of the widest diameter of the device and the shoulders. And then CO, we want to make sure that all the lobes of the appendage are covered. We look for little flow jets using T around them. We like to make sure there's no blood flow around the device. Anything smaller than 3 millimeters at the initial implant is considered acceptable. And this is actually one from our lab there. And you can see this patient also incidentally has a biventricular pacemaker as well. But that's the device. It's still tethered to the actual delivery system. We have not released it. We're going through all the different pass criteria. And then if everything looks good, you actually just counterclockwise rotate the little knob, and that unscrews it right there. And the device is free. And then afterwards, you just kind of look at it, make sure everything still looks okay. And very important throughout this whole procedure is that Dr. Jurgens is periodically doing a little sweep around the heart of the TE probe to make sure that there's no pericardial effusion. So the way this works is that it endothelializes after a period of time. That's why people require anticoagulants for 45 days, because the proximal face of this device is at least theoretically thrombogenic, particularly this little knob here where it screws in. But after 45 days, everything's all healed over, and that's when the anticoagulation is stopped. So follow-up. So everyone leaves the hospital on low-dose aspirin, and like I said, party line is warfarin as well. I think us at most centers end up whatever. If you're on something else, you go home on whatever you were taking before. If you're anticoagulant naive and haven't been taking anything, I send them all home on warfarin. But if they have been on Eliquis or Pradax or whatever, I just send them home on that for 45 days. And then at 45 days, they get their third TEE and make sure that there's no leaks around the device. And for the 45-day TEE, we'll accept anything smaller than a 5 millimeter sort of little jet of leak around the device on TE. And then if everything looks good at that point, we stop their warfarin or anticoagulant, They stay on aspirin, and at this point they're supposed to use sort of full dose aspirin, and then they start dual antiplatelet therapy here, just like they would for stent. So aspirin, Plavix for 6 months total. And this is sort of the timeline of anticoagulants and antiplatelet agents after the implant, warfarin and aspirin, then aspirin, clopidogrel, and then after 6 months they go on just aspirin indefinitely as destination therapy, is what they call it. So these are just looking at some of the some of the studies that have looked at it. The implant success rate is actually quite high, even with sort of newer people putting it in. And complications, you know, Protect AF, the first clinical trial, initially there was a fairly decent complication rate, about 10%, just a little bit on the high side, but they kind of refined the device and their techniques and cut that in half, and that has continued to decline over time. This just looks at sort of the complications. Tamponade, pericardial effusion is the big one, and stroke is the other one that we kind of worry about. Again, in Protect AF, the first half, there's a pretty good tamponade rate, but now that is actually very low. And again, the risk of these things are all very small. I don't know if you're familiar with looking at these sort of hazard ratio plots, but anything to the left of that little dotted line favors Watchman, anything to the right favors warfarin. And to be significant, not only does the little blue dot have to be on one side of the line, but all the little error bars have to be as well. So as you can see, nothing favors warfarin, but plenty of things favor Watchman in terms of hemorrhagic stroke, disabling or fatal stroke. There's actually a mortality benefit with Watchman as well, and then non-procedure related major bleeding. And then this is just another sort of scheme at looking at the chest tube VASC score and the risk of ischemic stroke. Obviously, the line with untreated patients is very high, but you can see that in terms of risk of ischemic stroke, the Watchman is just as good as warfarin, but with a 55% lower risk of disabling severe strokes. And then it sort of, the reduction in bleeding is seen right away as well, but as the follow-up continues out and you start discontinuing the anticoagulants and antiplatelet agents, there's an even higher realized reduction in the risk of bleeding. Risk of severe bleeding decreased by 72% after 6 months, and they're off all their other medications. So, you know, in general, it's a good device. It's a good alternative to warfarin or anticoagulants for people that have a high risk of stroke, and for a variety of reasons can't take anticoagulants. It has a high success, good implant success rate. The complication rate's fairly low, around 1.5%. The vast majority of people can stop their anticoagulant at follow-up. It decreases the risk of disabling strokes. It decreases the risk of hemorrhagic strokes, and there's also a reduction in mortality as well. So this just kind of hammers these points home as well in another form. But yeah, way lower risk of bleeding. And I think the mortality benefit is important as well. It's not one that we always think, oh, reduction of bleeding, but the mortality benefit is very important, obviously as well. So just kind of looking at patients nationwide who is or is not a candidate for the device. So if you consider about 5 million people in the population, and almost all of them have non-valvular. I mean, there's a handful that do, but the vast majority have non-valvular atrial fibrillation. And about 3/4 of them have a substantially elevated risk of stroke. At least for now, a complete absolute contraindication to anticoagulation is contraindication of the device, because it's supposed to be on anticoagulation for 45 days. So that sort of kicks out about 5% of them. And still, I mean, I love doing these things, but the majority of people do not want oral anticoagulants, and those people obviously aren't candidates for Watchman either. But a huge percentage of people are candidates for this device. I think it's a great device. I think just getting the sort of word out about it, getting this in people's mind is the most important thing that we can do at this point. So our own sort of experience at Methodist Hospital, we're coming up on our 1-year anniversary here pretty soon. Out of 38 attempted implants, 34 successful. The majority of those that weren't, you know, it's usually because the appendage was not as long as it was wide. And with the TE, we can usually get some sense of that. And most of these patients I've gone, you know, before the procedure, I've talked to them and said, I don't know if we're going to be able to do this. It's going to be a challenge. If you just want to bail and not go through any of it, you know, that's fine. So even the ones that we can't get it in, we usually have somebody when we talk to patients, they say, forget it, you know, if there's not a good chance of it, I don't want to do it. Most of them actually want us to give it a try though. And then so far, all the patients that have come for their 45-day TE have been taken off their anticoagulants. So just number of devices per procedure, you know, we're doing really well with that. Success rate, you know, not quite to the sort of top performers, but sort of getting closer. Hopefully we'll be soon. After you've done 10 implants, right? 10? Yeah. You get your name on the website. So there's my name on the website. Dr. Kuczynski's on the website now too. And this is just sort of going sort of in the future. This is the next generation of device. And this device is pretty cool because it's not quite as long as it is wide. So this will better accommodate these patients where the appendage is too shallow. It also has a little bigger membrane on it, so you can maybe accept a little bit more of a shoulder. This one you can actually you can push into the left atrial appendage a little bit, which you're not supposed to do with the current generation at all. But this is, they've already started doing clinical trials for this. You know, it'll be a little while before this one's available. But I think that this device, you know, we're still on a first generation device. This will be a substantial improvement. So we look forward to getting that one as well. All right. Any questions? Yeah.
Over time, do you have calcification problems?
Like, she was asking if over time if the device gets calcified. I'm not aware of that happening. Have you heard of that at all? No. Yeah. Yeah. Yeah.
Anywhere else they're doing it?
Yes, they do them at UNMC and Bergen as well. We all started last spring, kind of around the same time. So.
Is that acceptable holding when you just close them?
Yes, most of the time. And this was a big question we got, you know, when we first started doing atrial fibrillation ablations as well. Because with AFib ablations, when we first started doing, we were actually doing 2 transseptal holes. And most of them do close. We don't know for sure unless they get a repeat TE for another reason. But with atrial fibrillation ablations, there's a pretty high redo rate, and we end up getting a second, you know, another TE in those patients. And the majority of the time, it does close. But if it doesn't, I mean, we're not creating an ASD, we're creating a PFO. And 25% of people have a PFO anyway. So even if it doesn't close, it's not that big of a deal. So we're just reopening the hole that was already there, essentially.
You wait for that. If there's a clot in that appendage, that has to be done before you.
Absolutely, yes. That is an absolute contraindication to a clot of left atrial appendage thrombus. So, and so that when we're doing the left atrial appendage assessment in terms of size and trying to decide what device, yeah, we'd love to make sure there's no clot. That would be an absolute no. As soon as you put that pigtail cap in there, that'd be a good way to dislodge that clot and have it fly off somewhere. So.
Can the patient have an MRI?
Yes. Yeah. And I would, you know, I would encourage you to go look at one of the devices, and you'll see that this thing, if you have your eyes closed and someone just sets in your hand, you can't even feel it. It has almost no weight to it. It's a really delicate device.
Do you guys use a lot of dye when you're doing this? Injection of dye?
A lot is a relative question.
I mean, compared to, like, let's
Yeah,
say,
because
compared
you know, because what Dr. Kuczynski says is a lot, but to me a lot is like any. You know, because I never use it for anything. But for when he says, and I don't know, I honestly don't know what people use for a regular heart cath, but Ed says it's less. I don't know if you know, Nicole. So yeah, for a regular heart cath, generally people use 15 to 100 cc's of contrast. If we use, like, what'd you say, 20 or so? Yeah, yeah. Again, for me, that's a lot, because it's more than zero. But for Ed, he said, oh, this is nothing. Not a problem. But I always worry about that, because just like I was saying, you know, one of the risk factors for bleeding is renal insufficiency. So we do have a fair number of people with elevated creatinine and I always totally freaked out about it. And, you know, and it's like, oh, it's fine, don't worry about it. Again, and that just is important in terms of having a team approach to this. You know, we're very proud of the team that we have. All three of us. It's only the three of us. We do every case together. Every single TEE, from the screen to the inter-op to the follow-up, is all done by Dr. Jurens. We train together. When we went up for our training, most people did not have a complete team there. Training, you know, the interventionists go up one day, the TE person another day, but we trained as a team. We do all of them together. No one leaves the lab unless all three of us say, this is a good device. You know, all three of us have to give the thumbs up, not like two that say, yeah, this is great. And the other one say, I don't know, it's kind of, no, everyone has to agree. So, yeah, we're very proud of sort of the team that we do. And still, I think other places in the city or nationwide, you know, sometimes there'll be one person, one cardiologist, and you know, they kind of mix and match. But with us, it's always the three of us, every single case. Except for the two that I accidentally scheduled when Ed was in Europe. And I was very freaked out about doing those. So, but anyway, we'll do that again. Other questions? All right. Yes. Wait, one
Are
more.
you treating compliance patients as well?
What's that?
Are you treating compliance patients? Are you looking at those types of patients as well?
I do. You know, I don't want it to be just like, I just don't feel like taking any of this stuff. But I've had some patients that have had recurrent strokes on anticoagulants, and it was thought that perhaps the reason, you know, we talk to the patients, they're not always compliant with their anticoagulant, and I think that I think is a good indication if you're having strokes because you can't take it. You know, if it's just, I don't feel like it. You know, I don't know. I think cost is a reasonable option as well, personally.
How much do the devices cost?
Well, they're expensive. Yeah. They're you know, it's a tiered deal. You know, there's the price, and then if you do 12 a quarter, you get there's I think $2,000 discount price, and then if you do a lot of Boston Scientific defibrillators, they'll reduce the price as well. So.
Insurance and Medicare cover?
Yes. Yeah. All right.